Hello, today we're going to discuss and talk about how to position our patients for a distal AP femur. Let's begin. First, we will need our patient preparation. We will need to go out into the lobby, find our patients, and introduce ourselves and letting them know that we are going to take their images today. We shall bring them to the back and ask the patient to give us their full name, date of birth, and last menstrual period if needed. The image receptor size for this image should be about a 14 by 17 inch cassette or big enough to get the distal femur and knee joint. If we have a pediatric patient, we should use a 10 by 12 depending on how big the pediatric patient is. Our image receptor orientation should be portrait for this image. The image receptor location will be our table bucky. Our SID for this image should be approximately 40 inches from the table bucky. Our patient position for this image should be where our patient will be supined on the table with the femur censored to the midline of the table. We will be able to give the patient a pillow for their head for their comfort. This position may also be done on a stretcher with a portable grid placed underneath the femur if needed. The part position for this image should be for us to align the femur to the central ray and to the midline of the table or the image receptor. We must also rotate the leg internally approximately 5 degrees for a true AP as for an AP knee. We need to ensure that the knee joint is included on the image receptor considering the divergence of the beam. Our central ray location for this image should be perpendicular to the femur and the image receptor. We should also direct the central ray to the midpoint of the image receptor. The CR angulation for this image will be 0. We do not need any angulation on this image. The collimation field size for this image should be about closely collimated on both sides to the femur with the end collimation approximately around the film borders. The visual of appropriate marker locations for this image will be that our marker should be placed on the image receptor inside the table bucky or on the tabletop so long as it does not show up inside the needed anatomy that we are imaging. Our KVP for this image should be approximately 70 to 75 KVP. We should probably go forward closer to 75 depending on how big the patient is. Instructions for the patient for this exposure will be that we will need to tell our patient that they will need to hold still for us and not move while we expose for our image. If it is a pediatric patient, we will do our best to have them hold still for us before we take the image. We will watch them to take the image as needed. If need be, we will have to have other rad techs possibly hold the child to get the image needed. The anatomy demonstrated in this image should be approximately 2/3 of the distal femur, including knee joint, to be shown. The knee joint will not appear fully open because of the divergent X-ray beam. Items in profile for this image should include the femoral condyles, the intercondylar eminences centered to the tibia plateau. The pathologies best demonstrated or indicated in this image should be the detections and evaluation of fractures and or bone lesions within the body or the anatomy needed. And that is how we would set up our patient for an AP femur distal. Here we can see what the radiograph should look like, including all major parts of the anatomy that we need. That is everything that we have on how to position our patient for a distal AP femur.